Hello, everyone, and welcome to our webinar. Thank you so much for joining us today. I'm Jennifer Koenig with HealthCheck360. We have a great presentation for you today about how to control healthcare costs with HealthCheck360. Before we get started, I'd like to take care of a few housekeeping items. We will have time for questions at the end of today's presentation. If you have any questions, please type them into the question section at the bottom of your screen. We will also be posting a recording of the webinar online. So if you'd like to replay this presentation at a later date or share it with someone else on your team, it will be available. Today, we have HealthCheck360's Michael Kelly and Trent Tungan here with us to talk through how to control healthcare costs for your company. Financial pressures aren't just in the headlines. They are being felt by companies across the country, and the time to act is now. Today, we'll show you how to save over $2,000 per targeted member each year. So with that, let's get started. Michael, take it away.
Thank you so much, Jennifer. Although cost controls, as we think about with health plans, has been a focus of conversation since self-insured health plans were created. The reason we wanted to get together and talk about how we can apply chronic condition management, specifically as a cost control strategy, is because we think it's uniquely important to revisit right now. There's a great mix of employers with self-insured plans and benefit consultants that are on the webinar today. And we believe that the CEOs and CFOs of their clients and of their organizations are going to be asking their HR teams, their benefit experts, and their consultants some really challenging questions, if not already, but in the coming months on how to save money. And the question is kind of why. Well, I think most of the listeners probably know that the first major rationale for thinking about cost control now is the macroeconomic environment. Rising interest rates, a prolonged labor shortage, driving up employee costs, supply chain disruptions, driving up basic costs of goods sold, and rising energy costs also impacting bottom lines, creates a bit of a perfect storm for an economic slowdown or a possible recession. And everything out of the Fed kind of implies that we're not going to see a change in interest rates to heat up the economy until inflation is well under control. And I think that's going to be well into 2023. And so what that means is that companies are going to look for every opportunity to save money. And one of the first places that they always turn is to, hey, we have ongoing rising costs in our employee health plans. So the challenge in this environment, though, is with that prolonged labor shortage, how do we maintain competitive benefits while saving money through the health plan? And if we can go to the next slide, that second bucket around medical cost trend increasing is where we look to impact and can save significant dollars, but we have to do so in a way that actually still is providing competitive benefits and is doing so in a way that supports our employees to the best of their ability. And I think that's what Trent's going to spend most of the time talking about, is how we find that balance of a program that actually saves money, but actually achieves that through supporting employees in a way that's meaningful to them, beneficial to them, and even rewards them for picking the right track that drives those outcomes. And so, for many of the same reasons in the macro environment, we see rising costs on our health plans. One is there was a lot of deferred healthcare from 2020 and 2021. I saw something like almost 1 in 5 members of a health plan actually delayed some type of procedure during those timeframes because of the pandemic, and that's all going to hit our health plans, if it hasn't part of it already, in 22 and beyond. So much of this care is expected to rebound, this year, and much of it will also contribute to a higher spend in this fiscal year. In addition, we always kind of want to talk about the pandemic as if it is complete, but all of us know that it's not. So there's going to be continuation of COVID costs that are going to be persistent. treating patient with complex cases, employees being out, and the provision of care for those individuals, and even cases of long COVID on a lot of our health plans are demonstrating to be incredibly costly to plans. Many variables kind of go into this third bucket, but the mental health and substance abuse crisis certainly shows no sign of slowing down. And the claims associated for our clients with these are significant. They tend to be very, very large. And the opportunity to get our arms around mental health and behavioral health is a significant one. But until we're successful at that, or some of these trends abate, it's going to be a significant driver of costs now and into the near future. And the fourth one, which is something obviously we're really passionate about at HealthCheck360 and reversing, is that population health actually worsened during the pandemic, separate from COVID-specific costs. Pandemic-related health behaviors such as lack of exercise, poor nutrition, increased substance abuse, and nicotine use is actually kind of leading to deterioration in the US population health. And that will result in more of these chronic cases and increased healthcare spending. So everything that we talk about today is actually best supplemented with effective wellness programming, targeting many of these risk factors and getting those to lower so that we don't have as many chronic cases to deal with in the first place. But there is one big positive that I want to note on from the last couple of years. Both patients and providers learned that we can use digital tools to help us increase engagement and compliance with care. And what was great for us to see is that use of digital tools actually increased across all demographics. It wasn't just young patients. We had patients from every generational group apply digital technology in order to get the care they needed and to better understand what they need to be compliant and understand their conditions. And that's essential as we consider the volume of chronic conditions on our health plans. And I'm going to hand it over to our population health expert because the next couple of slides are going to talk about some of the volume, the costs associated with these chronic conditions, and then most importantly, Trent's going to share with us what we can do about it. So with that context, I'm going to hand it back over to Trent, and thank you, and I'll talk to you guys in a few minutes.
Sounds good. Thank you, Michael. Yeah, so as we talk about the condition management program and the impact that it can have in driving compliance, but then also in reducing costs, it's really important to dive a little bit further into those cost metrics that Michael started with. And there was one bullet point at the end of that previous slide that said 50% of the population is affected by chronic conditions, and that population can drive 85% or more of the medical spend. So if we dive into that a little bit further and look at two of arguably the biggest contributors to that area being diabetes and hypertension, we've got some recent stats here that says 11.3% of the US population is diagnosed with diabetes. And then if you look at that population, participants with diabetes cost 2.3 times more than somebody without diabetes. And then on the right side, you see 47% of adults with hypertension, and they cost about 2 times more than participants without hypertension. And so it's one thing to look at these conditions in isolation, but many times somebody with a chronic health condition has 2, 3, or 4 or more conditions along with it. So an example might be somebody with diabetes who also has heart disease. And then if diabetes and heart disease are not treated and managed appropriately, that can turn into chronic kidney disease. And so if you look here, you're looking at the number of chronic conditions. So starting with 0 conditions, this is data from the Healthcare Cost Institute that says that somebody with no chronic health conditions costs an average of $3,755 per member per year. And as you add on chronic conditions, going from 1 condition to 2 conditions, that per member per year cost doubles or increases even more than doubles with every condition that you're adding on. As you can see, it goes from 9,000 to 20,000. And so that's the trend that we really want to focus on and try to prevent that condition from worsening or developing into a second or third condition. So we're going to look at specifically on diabetes and outline how that progression and that cost can happen and how diabetes can multiply and turn into additional conditions. But it's really important to start off with the idea of, this is a statement from the World Health Organization, that diabetes can be treated and its consequences avoided or delayed with diet, physical activity, medication, and regular screening and treatment for complications. So really doing the things that I think we all can agree on are the right things to do if you have a chronic health condition. And if you do those things, you can avoid some of the complications that happen with diabetes. So if we look at if those steps are not taken, if somebody is not actively managing their condition, then diabetes can result in complications like neuropathy, that nerve pain can develop into heart disease. With diabetes or heart disease left untreated is the most common cause for kidney disease, and kidney disease then turning into kidney failure. And then you have additional complications that might result if wounds aren't healing in the feet and in the arms, where amputation can come into play. So along with those conditions and how that is escalating, along with that, if diabetes continues to not be managed correctly, then the RX cost increases. So you can see most common medication for diabetes being metformin, a generic medication on average. If you look online, it's about $20 per month. But if metformin is not enough to regulate the blood sugar levels for somebody, then we can start to look, most likely they're going to be introduced to more specialty medications. There's far more medications than what I have listed, but this just gives you an example of how that progression can look from $20 a month for metformin to $700 a month for Januvia and $1,300 per month for Trulicity. And so again, if that condition is not managed, that's how the progression in RX costs can look. Along with RX costs, then there's medical costs associated with that, where the member is starting to see more specialists. So if they have that neuropathy and they're starting to work with a specialist on the nerve damage, maybe they've got a wound and they're starting to go to a wound care program. There's going to be an uptick in ER visits. There's going to be longer inpatient stays, and then ultimately could lead to dialysis. So it's really a condition that, if not managed well, can progress quickly and really lead to very unfortunate circumstances. So the idea here being that there's steps that we can take to help these folks. I think many people on the call can probably think of somebody with a chronic health condition, whether it be diabetes or heart disease or heart failure, and somebody that just didn't do what they should to manage that condition. And they saw how that impacted their life on a day-to-day basis, where really medical care really became their primary focus each week. And they've got all these extra doctor visits and lab work and these things that really kind of take over their life. And that's really unfortunate. We don't want anybody to have to live that way. And so there's programs like ours that we can help participants so that they can focus on the things that matter. We'll help you to take care of your health so that you can live your life. You can go to work, you can be with your family and do those hobbies and focus on those things. But then also by doing so, we can help the medical plan save significant amount of money. So I walked through really an extreme example, but let's look at that a little bit further and seeing how prevalent that is. So there's a study done that said that 80% of ER visits come from adults who are 45 years or older. And in that group of adults 45 years or older, 1 in 4 of the ER visits came from somebody with diabetes. Diabetics were 24 times more likely to be admitted to the hospital, and their hospital length of stay was 15% longer. So higher ER utilization, more likely to be admitted, and longer inpatient stays. And then also we talked about chronic kidney disease. So 1 in 3 US adults with diabetes has chronic kidney disease, and chronic kidney disease with diabetic accounts for approximately 39% of all kidney failure cases in the United States. And so this is really where we can come in and we can help people to avoid these avoidable costs. if people are managing their condition correctly. So we're going to start to walk through, and I'm going to give an overview. I'll provide a demo of our app, and I'm going to provide some case studies to show the outcomes. Before we get into that, I really want to talk at a higher level about our program and some of the philosophical approaches that we take, because there are some things that we do a little bit differently, and we do those things for a reason. And I want to walk through some of those. So number one is supporting multiple conditions. And this is really important, as I mentioned, that people with diabetes, they're at an increased risk for heart disease, and they're more likely to develop chronic kidney disease. And so people have multiple conditions. And so having one place, one medical team, one program that they can turn to for the support that they need to manage that condition, as opposed to having one program that specializes in diabetes, a second program that specializes in heart disease, and maybe a third program to help with kidney issues. So one stop, one communication for the participant, one point of contact on the HealthCheck360 team. The second point is automatic enrollment. So we'll work with the carrier that the employer is working with, and we'll set up a medical claims feed and an RX feed, and we'll get 1 to 2 years of medical history and look back and be able to objectively determine who is being diagnosed and treated for the elected conditions. And so we'll use that data to identify those folks, but also if there's biometric data available, whether that's with HealthCheck360 or maybe there's another wellness program that we can partner with, and determine who is at high risk for diabetes, or maybe somebody is likely diabetic, they just haven't been diagnosed yet. So they get a glucose value back or a A1C value back that indicates that they have diabetes. We'll enroll them in our program. One of our clinicians will reach out and help that participant make contact with their primary care provider, initiate that treatment and start the treatment plan, and then we'll have them enrolled and continue to support that person. So we want to catch those people as quickly as we can so that we can start early and hopefully avoid some of those complications that come with unmanaged conditions. The other piece with the automatic enrollment process is that we want to make sure that we have the entire population. So diabetes, there can be people that are managing it really well, and we might say that they are at lower risk for complications, but we also know that there are people who are not managing it well, and who are at higher risk for those complications, and those complications leading to higher cost. We want to make sure we have the entire population, and not just allowing people who are ready to make change enter the program or opt into the program. When you do that, you tend to get the population that is already actively managing their condition, and and they're excited about it, and they're excited to have more support. That's great. We want those people to continue to work in the program, but we also want those people who are a little bit more resistant. Our team is very experienced in working with those folks and helping them to manage their condition and to understand the steps that they need to take. So we want to make sure that they're in the program so that we have eyes on them and they're getting the support that they need. Third is having that meaningful incentive design. So that incentive design, along with a communication plan and then a simple, easy to follow program, is really the key to some of these metrics of success, being number of people who are compliant and the reduction in medical costs. We'll work with you. We've got a great team of account managers who will help and provide ideas on what that incentive structure should look like. We've got the communication plan already laid out, and we can work with you. You can edit it as makes sense for your population, and we'll communicate with you and keep you in the loop. But having that in place is really important. Our clinical team, as they're reaching out to participants, all of our communications out to participants will also include that incentive structure as that motivator to stay in the program and understanding what the benefits are related to the incentive at the end of the program year for compliance. Third is we objectively define compliance. We follow evidence-based care guidelines. So the American Diabetes Association, the American Heart Association, and Center of Disease Control. And we look to them to be the experts in helping us to understand what is it that somebody with diabetes or hypertension should be doing on a daily, monthly, annual basis to best manage their condition. That's our ask. That's what we follow, and that's what we're asking and supporting our participants to do. So we then use their medical claims and RX claims to determine if somebody actually completed those steps. So participants don't need to submit anything to us. We will automatically know because we're going to be looking at claims feed typically on a monthly basis, and we'll be able to check the box for the participant. So they don't need to submit anything to us. So that's an advantage to the participant, but then also to the client so that they know that the metrics that we're providing are objectively based. There are programs out there that they may base compliance off of tracking or completing a phone call with the nurse. And while those are essential steps, those are important and valuable and part of our program, we don't feel that that's enough. We want to make sure that people are taking their medications and seeing their doctor and discussing their medications and discussing the data that they're tracking. Fifth on the list is being device agnostic. Participants can come into our program, and if they're already tracking their glucose or tracking their blood pressure, they've got a home device. We want them to continue with that. If they've got a good habit in place, we don't want to change it or break that habit. So they can use their device. They don't have to learn a new device and start using that. We want to keep them with whatever good habits they have in place, continue to do those things. If somebody doesn't have a device, we can provide a device. I'll talk a little bit more about that in a further slide and kind of give you some more examples of device options that we have. And then all of this together with an automatic enrollment process, working with participants with multiple conditions, that meaningful incentive and communication plan, and having participants follow evidence-based care guidelines really leads to meaningful results and an ROI. So I've got 2 case studies at the end that's going to demonstrate how we can increase compliance for the overall population, and then how that compliance then leads to a reduction in medical costs for those participants enrolled in the program. So that's a lot of information we covered in terms of what the concern is and how HealthCheck360 views it and sets up our program. But really the ask for participants is really simple. We want participants to fill their prescriptions, take all the medications that they are being prescribed by their doctor. We want them to see their doctor and to review lab work that they've had completed, to review the tracking that they've had completed, and making sure that the medications are on point, or if there's any changes that might need to happen to the care plan. And then third, we want them to build healthier habits led by them tracking their glucose and blood pressure on a daily basis. So this is the ask. Take your meds, see your doctor, and track. We have a mobile app that participants will have access to, and I'm going to do a demo here in a second. But the mobile app is really that go-to for the participants. It's 24/7 access for the member to know exactly where they stand in the program and what is the next step that they need to complete. So it really makes it easy for participants to always have access to a tool that's going to tell them, what should I do next? And it also keeps them on track to know if they're up to date with their compliance, or if they're not, when the deadline is. And so there's a lot of really neat features in the program or in the mobile app, but our goal was really to keep it as simple as possible for the participants and really have it, as you can see here on the screen, a program summary and then your to-do list. So I'm going to take a second here and pull up the MyCare360 app, and we'll do a demo there. Just give me 1 second while I find the right screen. Okay, so hopefully you can see the MyCare360 app that says, "Hello, John." So as a participant logs in, this is the first screen that they see, the program summary. So John is enrolled in the diabetes program, as you can see, and he can see where he stands with his care items, his medications, and his tracking. And he's got this red triangle by the My Cares indicating that something is out of date in this with his care items and on his to-do list. So he can tap in and learn a little bit more about what the My Care summary bar is showing. But he can come down and see right here, he's got an eye exam that is past due. So the eye exam was, the recommended due date for the eye exam was 4/1 of 2022. We're well past that, so it's showing up as past due. And so just a quick comment on that. An eye exam is due typically once a year. We see the medical claims, so we know that John last had his eye exam done on April 1st of 2021. So knowing that he can have it done again in 12 months, we put in a recommended due date of 4/1/2022. We want the participant to keep that continuation of care with their provider. So that's why we have that recommended date. But ultimately, John has until the December 31st of 2022, which is the end of his program year, to complete all of his to-do items. So you can see his to-do list. And as he scrolls down, he can see the items that he has completed. Again, we automatically move the items from the to-do list to the completed list as we get claims indicating that something has been completed. We look a little bit further at his to-do list, you can see his medication compliance. Let's say that John takes a generic medication though, and it's not one that's going to come through the PBM and through the claims file. That's okay. So John can come in and type in the medication that he's taken, so metformin, and he puts his last visit date. There's a camera feature that'll pop up, and John can just take a picture of the pill bottle and submit that. So his entry was submitted. And one of our nurses on our team is going to review that picture and make sure that it is the right pill bottle, the right medication, and it's for John. And then we'll automatically mark that medication as complete and update his medication compliance. And so that feature works really with any of the items here. So John can come in and say he completed his next office visit, he can submit it. And then as we come down, we can see, okay, this is in pending review. So one of our clinicians, again, is going to review this. Once they review it, they'll either mark it as complete and move it down, or if it doesn't meet the needs of what this care item is asking for, we'll reach out to John and explain, hey, I see the office visit, but I'm missing your name. I can't see that it's actually for you. Can you resend? Or it looks like this is the wrong date. This was for last year. Do you have the one from this year? However that conversation might go, but our team will reach out to John and make sure that he's in the loop and understands exactly where he stands. Also, when care items are coming up as due, we're going to send push notifications through the app. So John's going to get a reminder 30 days in advance that you have a care item due. Now's the time to get that scheduled. If that care item date comes and goes, he'll get another notification that indicates that this is past due, and you should reach out to HealthCheck360 and we'll help to get you that item scheduled. At the same time, that will also trigger a phone call from our team if something is past due. We'll reach out to John proactively and help him and explain what is past due and what he needs to complete in order to keep his compliance. So really simple to follow. John knows where he stands in the program, and he sees his to-do list and what is necessary to complete next. John can come in and read more about the condition management program, and this red text is where we'll put information specific to the client's program. So what's the program deadline? What's the incentive structure? Any other information that we might need to put into the program, we can add that there. John can request a call. You don't need to do this. We find that actually a lot of truck drivers like this piece. They might know that they're going to be unloading at 3 p.m. today. And so they might say, hey, can you call me at 3 p.m.? I'm going to be off the road and able to talk. And so once that happens, an email will go to our team and we'll automatically, we'll do our best to reach out to that participant at that time. But really, as soon as somebody is engaged in our program, they're going to get a phone call from one of our clinicians explaining the program and giving them a direct contact. And so they'll be able to reach out to their individual clinician as much as they want throughout the program. They don't need to schedule a call. Anybody can call and email us as much as they like. But sometimes it does come in handy if they know somebody's driving and they know they're going to be free at 3 o'clock. So it's a feature that we do find people like to use. We can also look at the tracking. So glucose and blood pressure being two examples. And we have a few different ways that we can enter tracking data. So you can see here John's history. He's been tracking twice a day. And today he's got 2 readings and able to put in notes that this was a fasting reading right at breakfast time, and this was a non-fasting reading at dinner time. And there's options here where John can enter in his information manually, add in notes. So we put in 119 and that third reading for the day pops up. You can see it's 119 is now added to the chart and to the list. There's an option for participants to scan a device. So this is a really neat feature that we have where participants who do not have a cellular-based device or a Bluetooth-based device can come in and select a device that they have, and a camera feature will open up for them where they take the reading, the camera feature digitizes the reading and submits it for that participant. There's also an option where a participant can connect a Bluetooth device. And so here's an Omron blood pressure connection that you can see. And so Omron being a very common blood pressure cuff and one that we can provide participants. And so they can have that Bluetooth connection as well. We also have many participants that have a connection and they link everything in through Apple Health. And so Apple Health being a really great aggregator, or Samsung Health, and they can submit that information to us so that we can get that information. So we have multiple ways that we can work with participants to make it easy for them to submit that information. You know, one-time setup and then just let the Bluetooth handle it, or Apple Health, however that mechanism works. So it keeps it really simple and easy for the participant. So yeah, the goal here was really to keep it as easy as possible for the participant, and just one screen really gives the participant all the information they need to know. Again, where they stand in the program and what items to complete next. So with that, I'm going to go back over to this slideshow. One second as I get us back to where we were. Okay, so we covered the MyCare360 app. Let's talk a little bit more about the devices. As I mentioned, our program is device agnostic. So if somebody has a device, they can bring the device that they have, which is great. But it's really important that tracking is included because it helps participants to know how they're doing with the program, how their medication is working, and what impact their lifestyle choices, whether that's stress, or maybe they just were diagnosed with COVID and they're taking different medications for that, or their nutrition or exercise, and they can see how those different components are impacting their blood sugar or blood pressure on a day-to-day basis. It's also really helpful because if somebody submits a reading that is elevated, our clinicians are going to reach out to that person. And it's a really important time for education and helping that participant. So first off, we want to make sure that they're okay. So if they have a very high blood pressure or blood sugar reading, we want to see what symptoms they have, and our team is going to guide them on what the next appropriate steps are, whether they need to call 911, go to the ER, or schedule an appointment with their provider. From there, then we'll also work with them to figure out what drove that high number. Maybe somebody decided just to stop taking their blood pressure medicine. You know, that happens where they'll have several weeks where their blood pressure readings are at a normal range. And so they say, oh, my blood pressure is great, I don't need to take my medication anymore, and they opt out of taking it. And so our clinicians will reach out and help them understand you shouldn't stop taking medications without talking to your provider first. But also, the reason that your blood pressure readings were in a healthy range is because the medication was working. So you should continue to do that. So it really does provide opportunities for engagement and support from our clinician team. We can provide devices, as I mentioned previously. We have options there in terms of if we want to provide a cellular device or a Bluetooth device, whether that's a glucometer or blood pressure cuff. We can work with you. We have options. So we can be in contact with your PBM and figure out what is the preferred device on the PBM, and that's important really around diabetes and getting test strips refilled. So if we provide somebody a glucometer and they're traveling and they need to get new test strips, they can go to Walmart, CVS, or wherever and get those that are covered by the plan. So we have options there. And we also have options in the program design and how we incentivize those different readings and whether we are requiring the readings on a weekly basis or if we're encouraging those readings and what conditions are included with that. So things that our account management team can support you with and decisions that we can make. So along with the devices and the mobile app, we have other communications that we're providing to participants on a regular basis. So as soon as we enroll somebody into the program, they're gonna get a welcome kit sent to their home. And we're also going to have one of our clinicians reach out to them to introduce them to the program, help them understand what the ask is of the program, the incentive structure, the program year, what are all the items on their to-do list, help them download the HealthCheck360 app and just get them set off on the right foot, as well as doing a medical overview of the medications that they're currently taking and setting some goals around their lifestyle in terms of nutrition and movement, things like that. So really trying to help the participant, and then we're there for them as much as they need us. We'll also provide quarterly emails to the participant. There's the push notifications through the app. I mentioned a couple of them, but there's several. So if a care item is checked off, they'll get a push notification indicating that so they can go and review if they would like. If a care item is past due, we've got quarterly reminders to say, it's been 3 months, now's a good time. Let's make sure that you've reviewed the app if you haven't done so lately. End of the year reminders that your program deadline is coming up in 30 days. So really want to work with participants with multiple communication channels so that we can engage everybody. And then of course, unlimited support. Anybody can call us, email us as much as they would like throughout the year. We want to work with everybody and answer their questions and support them as much as we possibly can. So along with communication to the participant, there's also, of course, important to have communication with the employer. So we'll provide regular reporting to the employer. So typically it's on a quarterly cadence, but we can work with you on that. And providing high-level aggregate information. So how many people do we have enrolled in diabetes? What's the average compliance so far, in quarter 1, 2, 3, and 4? If compliance is, where are we seeing the biggest impact on compliance, or what areas do we need to focus on? Is it driven by eye exams or medication refills? And then we can work with you and help to provide specific communication pieces that we can either send out, or if you prefer to send those out. So just targeted mailings that, as we have these discussions, we can work together on figure out, okay, here's the strategy on how we can increase the number of people who are completing their eye exams. And so our team has great resources around that and different drafts of things that we can use and provide to the employer. And then we'll have a similar type of page for all of the conditions. So I mentioned earlier, diabetes, hypertension are 2 of the most common ones, but we work with 7 different conditions. High cholesterol, coronary artery disease, heart failure being other ones that people commonly add on. But we can work with you and maybe it makes sense to start with 2 conditions and add on, 3 or 4 as we see the reporting down the road. So it's really an a la carte approach. You don't have to work with all of the conditions. And then along with the engagement, we'll also provide claims analysis and cohort analysis as we complete year 1 and as we complete years 2 and 3. That really starts to help us see the trend and the overall spend for people with the selected conditions on the medical plan. And so with that, I'm going to dive into the case studies, and this will also give you an idea of the type of reporting and outcomes that we're going to be able to provide each of you and your clients. So here's an example that had 230 participants enrolled between diabetes and hypertension. At baseline, so before they started to work with us, there on the far left, you can see diabetes compliance was actually at 0%. And unfortunately, that's not uncommon. Now, 0% doesn't mean that everybody with diabetes was doing nothing. It just means that there's people, nobody that had diabetes was doing everything that they should be doing. They might be taking their medication, but they might have been skipping the eye exam, or they might have been skipping one of the A1C tests that they should be having. And so our goal here is to make sure that they're checking off every box and making sure that they're up to date with all of the recommended care items. So you can see from baseline to the year 2 in spring, we went from 0% to 71% compliance. And again, I can't stress this enough or repeat it enough that there's 2 things that's really important with that 71% number. One is that it's every single diabetic on the medical plan. Everybody is enrolled in the program. So it's everybody, not just people who opted into the program. So you know that 71% of all of your diabetics are compliant with the recommended cares. The second thing is that is objectively measured. That's based off of claims data indicating that they're refilling their meds, they're getting their lab work done, and they're seeing their doctor. And then also we know through the mobile app if they're tracking their blood sugar or blood pressure. So really profound increase in engagement and compliance. And same is true with hypertension. So that light blue went from 13.1% at baseline to 83% at the end of year 2 in the springtime. Then COVID happened. So as we move to the right there, you can see COVID happened and we were able to adapt. And so we stepped in, had a conversation with the client and said, COVID is making it actually impossible for some of your members to become compliant because many offices have closed down and not allowing people to go to the doctor for some of the routine care items. Those are being pushed down the road, as Michael indicated in his earlier slide. So we adapted and said, we recommend that we shift to adjusting compliance to be based only off of RX compliance. So you can see the introduction of kind of that gold and light green bars there. And so that's showing your diabetes RX compliance and your hypertension RX compliance. We still wanted to show the client where they at with total compliance for both of the other conditions. But for that year, they were looking specifically at RX compliance. Then in the following year, we went right back to the full compliance and we're able to keep compliance at 68% for diabetes and 77% for hypertension. And so that's just one of the pieces too that our account management team really excels at, because shifting compliance in the middle of years is not really an easy thing to do. It takes a lot of communication and a lot of planning, but you can see here how the rebound into year 3 went off without a hitch, and we were able to keep the compliance up. And that took a lot of work from the account management team. And again, we own that work. So it's not something we expect the client to do. We will guide and support you every step of the way if things like this happen again. Hopefully we don't ever have to do that again, but who knows? So with compliance being high, then we wanted to look at the year over year trend in the per member per year cost. So this slide is looking at the same group, specifically at those with diabetes. So you can see in year 1, the average per member per year cost of somebody with diabetes out of this population was $14,193. In year 2, that cost decreased to $11,868, and in year 3, $11,768. So compared to themselves, you can see that the diabetic population was decreasing their per member per year cost. But this client said, well, that's great, but how do we stack up against the rest of the world? And so great question. So we put in a benchmark, which is that gold bar there. And so partnering with one of the TPAs that we work with, we looked and were able to pull in, okay, let's take the average cost of a diabetic for each one of those years. And that's what that gold bar is looking at. So in year 1, they were right at benchmark. And then year 2, you can see benchmark came down a little bit. That, again, that's COVID year where utilization dropped. And so the average costs were decreasing. And then we saw a little bit of a rebound in year 3 on that benchmark data. And then that sort of light teal green is the comparison from benchmark to this client's cost. So in year 3, the group was $2,833 below benchmark. So really a great trend compared to themselves and compared to benchmark. And if we add that up, given the number of people that they had enrolled with diabetes, the 3-year savings over the course of that period for diabetics was about $330,000 in medical cost reduction. And same idea when we look at hypertension. So the exact same type of chart, you can see their participants with hypertension, the per member per year cost started at 8,444, and in year 3 declined to 6,860. So a good trend down. And then also comparing it to benchmark, in year 3, the difference from benchmark was $2,470. So again, if we do the math there, they had far more people enrolled in hypertension than they did in diabetes. So the 3-year savings was almost 500,000 just for the hypertension population for this group. And one more longer case study here, and this is looking at a transportation client over the course of 5 years. You can see that they had diabetes and hypertension as their elected conditions. And in year 1 at baseline, their diabetics, they had about 4% of their diabetics that were compliant. I think I forgot to mention this earlier. I mentioned that that's normal for us to see that, but typically we see diabetes compliance at baseline at around 10% or less. And then for this particular group, their high blood pressure population was at 45%. This is actually a little bit higher than we typically see. Normally it's about 30 to 35%. But then at the end of year 1, we were able to drive up those numbers for diabetes from 4% to 75%. And then you can see year over year, we maintained a 70% or higher average compliance. And same thing with hypertension, from 45% to almost 90%, and then maintaining 80 to 90 plus compliance from year over year. So the program works. It's simple to follow. We've got a great communication plan and a mobile app that really makes it easy for participants to know what they need to do. The ask is in line with what their doctor wants them to do. We're not trying to change that, and we're not trying to replace that. We just want people to take their medications, get their lab work done, and see their doctor and discuss that lab work. We also want them to track their blood pressure or blood sugar on a regular basis. And when you do that with the communication plan and the incentive structure that our team can support you with, you can see how we can drive compliance rates up and maintain those compliance rates year over year. And again, this is all of our reporting is going to be based off of the whole population and is based off of objective data. And when we see that happen, you can see, and it makes sense that those number of ER visits are going to decrease, the number of inpatient days are going to decrease, and preventing that diabetes or hypertension from progressing into or causing neuropathy, a heart attack, or chronic kidney disease, as an example, conditions or ailments that are far more costly and expensive. So Jen, with that, I will take a deep breath and a sip of water, and we can open it up to any questions.
Wonderful. Thank you so much, Trent, and thank you, Michael. We appreciate your time today sharing these strategies on how to get results. Like Trent mentioned, we'd now like to open it up to our audience to ask a few questions. As a reminder, if you have any questions, please type them into the question section within the Zoom platform. And Trent, we have gotten several questions in so far. And our first question is around implementation. So does this program need to be implemented at renewal?
Yeah, that's a great question. And the answer is no. It doesn't need to happen at renewal. Renewal time is coming up on not too far away, which is kind of scary to say for a lot of groups turning over on 1/1. But no, it doesn't need to. We can actually implement the program now, introduce it to all of the participants, and get them working with our nurse, get them on the HealthCheck360 app, and help them to understand what the ask is, and just making it really easy for them to know. And then on 1/1, we can shift it over and maybe that's where you turn on the incentive, because now they got a 12-month period. Doesn't have to be 1/1, whatever the program year is. But great question, good thought, and no, you don't need to wait until renewal.
Great. Trent, the follow-up question is, how long does implementation take?
Yeah, another good question. Honestly, the hardest part with implementation is I mentioned that we're going to work with your carrier and make sure that we're pulling in the medical claims and RX claims and census files. And we do all of that work. And that's really the part that takes the longest is we'll initiate everything. And then we kind of, go onto the list of the carrier's IT department on when they're going to send us those files and start that SFDP, because we'll get those files on a monthly basis at least. So that might take a couple months for us to complete that. While that's happening, our account management team will work with the employer and set up an overview of the program. We'll talk about the incentive structure and just make sure we've got all of those pieces in place. So when those claims are there, we can kick off the program and start going.
Wonderful, thank you. Trent, can you share the incentives for the case studies that you presented just a few minutes ago?
Yes, so they each had incentive structures in place, and it was right around $50 per month was the incentive that was in place for both of those clients. And so again, that's all communicated on the mobile app. It's communicated on phone calls to the participant, emails that we send out. So make sure that everybody's well aware of what those incentive structures are.
All right. Trent, the next question, this attendee is wondering what happens if the participant or someone in the program has multiple conditions?
Yeah, that's a great question. That happens where somebody has hypertension and diabetes at the same time. And so we'll keep them enrolled. And the ask is the same. And so really they're completing the same program where take your medications, all medications as prescribed. And so we'll have the list of medications related to diabetes and hypertension, and we'll be monitoring all of those. They still need to do their annual doctor visits. There might be additional lab work done, maybe not with hypertension, but if high cholesterol is added to the program, we'll add a lipid panel to their to-do list along with their A1C as an example, and liver and kidney function test. So they'll have one to-do list. It'll all be in one spot, and it'll show everything they need to do. So they don't have to toggle between a to-do list for diabetes or a to-do list for hypertension. It's one spot that gives them all the information and outlines their program requirements.
Excellent, thank you. The next question, Trent, is what happens if someone is diagnosed in the middle of a program year?
Yeah, again, that can happen. And that's a comment I didn't get to, so I'm glad they brought up that question. We'll run enrollment regularly throughout the year. So we're going to get the monthly claims feed, and we'll get the biometric data whenever it's available. And we'll continue to run enrollment regularly. And so we will add people on in the middle of the year. We'll work with you and recommend a cutoff date. We'll absolutely enroll that person in the program, regardless of if it's a month before the deadline or what have you. We want them to get the app and start to understand what it is, but they may not be held to the same incentive structure. If there's 3 months left in the program, they're not going to be able to get 2 A1Cs completed and the like. And so we'll work with you on whether we focus just on their medication compliance, or if we, just one office visit. So we have different recommendations, but most important thing is get them in the program and engaged with our clinical team and on the app.
Thank you, Trent. We have another question around enrollment. And this attendee is wondering if members can self-enroll.
Yeah, believe it or not, that happens. Yeah, so we'll get people that, we'll communicate the HealthCheck360 or condition management program. It'll be in the benefits guide that goes out to all the employees. And so, somebody did their due diligence and read it and saw that this program is available, but then they got diagnosed. And so they'll go into the HR office, or they'll call us, and and HR might refer them to us, or they'll call and say, hey, I have diabetes, and we'll say, okay, we don't have the claim, the indicators for it yet, but let's talk about it. Have you been to the doctor? What medications are you on? And so we'll get them into the program and get them going. So best case scenario is they tell us before we get the claims for it. That means we've got an early start.
Absolutely. Trent, back to incentives. Are the incentives separate and distinct from like a biometrics incentive if the client has a biometric screening program, maybe in addition to the condition management?
Yeah, that's a good question. Michael, you might actually have a little bit more context on this one. If you want to take that.
Yeah, actually, Jennifer, we have clients that do both. And so one, we have kind of layered incentive structures where they are exactly how the question was written, where the incentives are separate and distinct, meaning I can earn one that has no repercussions on the other. We have other clients that say, hey, compliance with your chronic condition is the minimum requirement to entry, right? Before you can earn anything, you have to meet those expectations. I think it's important to remember from an incentive perspective that everything that we're asking somebody to do in this program is participatory in nature, right? We're asking them to simply complete the tasks that the leading experts recommend for these conditions. We're not asking them to get a specific outcome on a test or a value. We're asking them to make sure that they're doing those things. And then we see and consult on the values of those things over time, right? So we want to see movement. And that important distinction allows for a great deal of flexibility on how we design the incentives. And so, the answer to that question is both. We have people that say, hey, you if identified, you need to complete these in order to earn the wellness incentive also. And then we have other groups that say, hey, there's X value for completing the condition management aspect of a well-being program, and there's Y value for completing the wellness biometric or engagement aspect of a well-being program. And by the way, both models are effective. And so as Trent notes that we work with groups on the best possible incentive model, those are some of the discussions that we have.
Thank you, Michael. A follow-up question to the incentive conversation. Are those incentives paid out monthly?
Sure, the incentives typically are earned monthly, but if the question is related to do we go back and forth, we typically don't recommend that because of the nature of some of the things that we're asking people to do in terms of, two annual A1C tests or an annual eye and feet office appointment for diabetics. We don't want to switch things back and forth every month because people have typically, as Trent showed on the app, a set schedule that they're completing these things. So typically we want to provide people the flexibility to complete those things on their schedules. We actually provide, as it showed, the communication, the heads up, and the reminders to get those things done. But I think it's typically in both the employers from a payroll and HR perspective, but also the employee to not shift those things every month. I think the trend, the most often we have groups change back and forth is quarterly. And I still think most programs run best on an annual basis.
Yeah, quarterly is very challenging because claims lag happens. And so to do it quarterly, when we get those claims, it's maybe a month or 2 months. So we've got to allow time for everything to happen. Our best recommendation and in terms of ease for the HR teams is keeping it annual. We'll provide the report as much as they want, but a lot of the work then at that point, once we provide the report, falls on them. So that's part of the reason we also try to keep it annual.
Wonderful. Trent, this attendee is wondering, what is the employee feedback that you receive or that you see our clients receive on this type of a program? This person is wondering specifically if it hurts employee satisfaction at all.
Yeah. Actually, that's the biggest conversation piece that we have with prospective clients. We work a lot with the transportation industry as an example, and turnover in that space is top of mind for everybody. And so I actually just had that exact conversation with a large transportation group this week, and we're kind of reminiscing about how that was the thought, but it never happened. Where there might have been 1 or 2 people that came off the medical plan, but there wasn't a mass exodus or even a significant exodus at all. And I mentioned earlier, we've got a team that's been doing this for several years, and they're really good at talking to people and helping them to understand the nature of the program. Once we can work with them and introduce them to the app and how easy it is and what the ask really is, we're not trying to change their medical plan. We're there to help. And so if you've got people that have a chronic health condition, as we mentioned earlier, that can be such a burden on their life. And so if they know that we're in their corner and we're there to support them every step of the way, we can help them to understand the real goal of the program.
Wonderful. Thank you, Trent. I think that is all of the time that we have today. And I think that's a great note to end on. I know I put myself in a participant's shoes, and I know I would want that support. So thank you again, Michael and Trent, both of you, for your time today. We hope all of our attendees enjoyed the presentation. You will receive a follow-up email with links to the recording. And as a reminder, you can get updates on all of the latest from HealthCheck360 by following us on LinkedIn and subscribing to our blog. This concludes today's webinar. Stay safe, stay healthy, and take care.
Thanks, Jennifer.
Thank you.